Okay, good afternoon, everyone. Thank you very much for joining us today. My name is Marcela Gaitan, and I work with the National Alliance for Hispanic Health. I'm the program director for the Nuestras Voces Adelante Network program. I'm very excited that you are joining us today for this great program. This is our third installment for the webinar series, and we're doing the program today is Integrating Nutrition and Healthcare, the Essentials of the Food is Medicine Initiative. The program is being hosted by the Tri-Networks Cancer Prevention Community of Practice, and I'm thrilled that everybody was able to join us today, and I'm also very happy to have great presenters for our program. Next slide. I just want to mention a couple of housekeeping details. Everybody has been muted, so that way we won't have any interference with noise. Also, after the presentations, we will have time for a Q&A session. So during the presentations, feel free to write your questions using the Q&A feature. And at the end, we will address the questions that you had provided. Also, at the end of the session, we will provide a QR code so you can complete a really brief evaluation survey. And then in addition, all the participants will be receiving a post-webinar email that contains the recording, the slides, and the evaluation survey, just in case you're not able to complete it during the program. And we just want to remind you that the evaluation surveys are important to us because it helps us to improve, and then for future programs, it helps to improve and also find even topics for future programs as well. Next slide. So what are the Tri-Networks Cancer Prevention Community of Practice? Next slide. The Tri-Networks Cancer Prevention Community of Practice is a collaboration between 3 of the CDC-funded national networks: the Geographic Health Equity Alliance, Nuestras Voces Adelante Network, and the Self-Made Health Network. The goal of the program is to build capacity and capabilities of the National Comprehensive Cancer Control Programs, cancer coalitions, and other allied partners to implement PSC, policy, systems, and environmental change strategies to reduce cancer-related health disparities. The program aims to bolster interventions that address the needs of underserved communities, including those with low socioeconomic status, Hispanic, Latino communities, and geographically defined populations as well. Our focus are HPV vaccination for cancer prevention, improving the built environment and physical activity, ensuring food and nutrition security, and expanding broadband access. I'm really excited to introduce our presenters for today's program. Next slide, please. So first, we're going to have Heather Latino, who is an attorney and clinical instructor at Harvard's Law School Food Law and Policy Clinic. Her work is centered on enhancing access to affordable, safe, and healthy foods by advocating for innovative measures and policy improvements in nutrition assistance programs, food systems integration, food waste reduction, and food recovery. She works closely with her colleagues at the Center for Health Law and Policy Innovation to expand access to high-quality, nutritious food for patients, nutritious food for patients living with or at risk for diet-related illnesses. She is passionate about creating a more sustainable, resilient, and equitable food system. Next slide. We also have another presenter, and her name is Meghana Iragavarapu. Meghana is a graduate student in nutrition at the Harvard T.H. Chan School of Public Health. She graduated from Duke University with a Bachelor of Arts in the intersection of food availability, nutrition, and health outcomes. It was a major that she actually designed at Duke. With a strong foundation in health policy, she has explored research and advocacy, focusing on food justice, digital health, and addressing nutrition disparities. Before Harvard, Meghana had a diverse experience. Her diverse experience includes roles in research, policy development, and community service, reflecting her commitment to leveraging food as medicine and enhancing healthcare through innovative solutions. So without much further ado, I'll give the podium to our presenters today. Thank you.
Great, thank you. I'm just going to get set up with screen sharing here.
All right, perfect. So welcome to our webinar titled Integrating Nutrition and Healthcare and the Essentials of the Food is Medicine Initiative. Before we begin, we want to make sure we thank Marcella for not just the lovely introductions, but also reaching out to us and giving us this opportunity, as well as the Tri-Network's Cancer Prevention Community of Practice. We are so excited to be here with you today. And so if we want to actually go to the next slide, and we'll see what we're actually talking about. Awesome. So the first thing that we're going to go through in our time together is the definition of what we mean as food as medicine. And this is in recognition that food as medicine can mean different things to different people, to different practices, but we're going to level set for our presentation today. Then we're going to sort of understand the landscape of diet-related disease that food as medicine is responding to, and then cover the projected impacts that food as medicine is supposed to have nationally through health outcomes and healthcare savings. And then finally, we'll cover the unique funding pathways that have emerged for supporting food as medicine nationally, statewide, and locally. So with that, I'm going to pass it over to Heather, who is going to define food as medicine for us.
Thank you so much, Meghana, and thanks everyone for being here. Food is Medicine Massachusetts, which is a multi-stakeholder coalition that our clinic has helped lead, defines food as medicine as a spectrum of services and health interventions that recognize and respond to the critical link between nutrition and chronic illness. Food as Medicine has three primary goals. The first goal is to increase access to healthy, affordable food for patients and their families. The second aim is to leverage community resources and expertise to address food insecurity and chronic disease. And finally, and perhaps most importantly, it aims to improve health and overall quality of life for patients. Food as Medicine interventions respond to the nexus between food and health by helping to prevent and treat diet-related diseases. On the right-hand side of the screen, you can see the Food as Medicine pyramid. And this is a tool that we use to help explain how different types of nutrition programs and food as medicine interventions relate to one another. As you go up the pyramid, the interventions are more intensive, and they also serve a smaller segment of the population. They're also more effective at not only preventing, but also treating diet-related illness. The two bottom levels of the pyramid are population-level healthy food policies and programs, and nutrition security programs. These are not food as medicine programs, but they do support food as medicine initiatives. One example of a program that we do not consider to be food as medicine is the Supplemental Nutrition Assistance Program, more commonly referred to as SNAP. By assisting food insecure families to purchase food, SNAP promotes health. But SNAP is not a food as medicine intervention. Food as medicine interventions have two defining traits. First, they provide access to healthy food, such as through providing vouchers for produce or by providing food directly in the form of groceries, meal kits, or fully prepared meals. The second defining trait is that it has a nexus to the healthcare system. In other words, a medical professional is involved in prescribing the intervention as part of a patient's treatment plan. Three common types of food as medicine interventions are produce prescriptions, medically tailored groceries, and medically tailored meals. And we'll explore all three of these programs in more depth on the next slide. Starting with produce prescriptions. Produce prescriptions help patients eat more fruits and vegetables. Programs offer free or discounted produce, typically through a voucher or electronic benefits cards. A program could, for example, provide participants with a set amount of money to redeem at a grocery store or a farmer's market for fresh produce. Produce prescriptions are for patients that have diet-related health risks or conditions, such as diabetes, prediabetes, hypertension, and obesity, in patients who also struggle to afford healthy food. As we move to the center of the screen, we'll talk about medically tailored groceries. These are packages of foods that patients can cook and eat at home. And the food packages are designed to meet all or most of the patient's needs. Food packages can range from boxes of fresh foods to meal kits, like something that you might order from Blue Apron. And medically tailored groceries can also be picked up. Sometimes this is at a healthcare facility, or it can be at other locations such as community food banks, while other programs actually are able to deliver medically tailored groceries to a patient's home. Medically tailored groceries are for patients who have medical conditions such as diabetes or hypertension, but who are still able to shop and cook for themselves. And the food packages are typically designed by a registered dietitian based upon the medical condition, but they're not tailored to the patient's specific dietary needs. And the last category of food as medicine initiatives that we'll talk about, or programs that we'll talk about, are medically tailored meals. And these are home delivered, fully prepared meals that are designed for a specific patient. These meals respond to all of a participant's diet-related illnesses and any other health conditions that they might have. These are typically for patients who have severe or complex medical conditions, such as poorly controlled diabetes, heart failure, cancer, kidney failure, or HIV, conditions that make it difficult for them to shop or cook for themselves. These range of nutrition interventions, which involve the direct provision of food, are often paired with other interventions as well, such as nutrition education, or programs that also help supply essential cooking equipment, such as microwaves, pots and pans, or cooking utensils. And with that, I'm going to turn it back over to Meghana to introduce the next section of the presentation.
Wonderful. Thank you so much, Heather. So now we're going to move into discussing the evidence-based case for food as medicine. Next slide, please. So we first have to understand the need that food as medicine is responding to in order to fully understand the benefits that food as medicine programming is projected to have. And so we've included 4 statistics here to try and offer an overview. So the first one is that projections show that only 1 in 10 American adults are thought to eat the recommended daily amount of fruit or vegetables. And the gap is even more pronounced among those earning lower wages. The second statistic is that unhealthy diets are shown to contribute to approximately 678,000 deaths each year in the United States. And this is due to nutrition and obesity-related diseases such as heart disease, cancer, and type 2 diabetes. And in the last 30 years, obesity rates have doubled in adults, tripled in children, and quadrupled in adolescents. The third statistic is that over their lifetime, US adults overall have a 40% chance of developing type 2 diabetes. But for Hispanic and Latino adults, that number unfortunately rises to more than 50%, and it's likely to develop at a younger age. And diabetes complications also hit harder. Hispanic or Latino populations have high rates of kidney failure caused by diabetes, as well as diabetes-related vision loss and blindness. And finally, we would be remiss to not mention the healthcare cost. That according to the Rockefeller Foundation, the United States spends $1.1 trillion on treating these chronic diseases related to diet each year. And I know this isn't on the slide, but we also should note that food insecurity is also associated with similar chronic conditions. So now that we've covered sort of the landscape of what diet-related disease looks like, we can now move into the benefits. So we want to highlight some of the reasons that there has been such an immense momentum to implement food as medicine across the country. As we'll go through on this slide, there are real positive health and healthcare outcomes with these interventions. So to begin on the left, the health benefits. Studies have shown that food as medicine interventions, such as the ones that Heather covered earlier, such as medically tailored meals or produce prescriptions, these are associated with significant improvements in fruit and vegetable intake for participating people. Documented clinical improvements are also shown in hemoglobin levels, blood pressure, and BMI for adults with poor cardiometabolic health. Moving to the middle of the slide for hospitalizations and healthcare expenditures, important modeling that happened in 2023 detailed that the national implementation of medically tailored meals could be associated with 1.6 million averted hospitalizations in just the first year, and a net cost savings of $13.6 billion in healthcare costs. Even more dramatic is over 10 years. So if we were able to nationally implement medically tailored meals over a 10-year period, this was supposed to be associated with 18,257,000 averted hospitalizations and a net savings of $185.1 billion. Big, big numbers. And finally, we want to move to the healthcare outcomes. So another projected model showed that implementing produce prescription programs for those at risk of diabetes or living with diabetes in the United States said that if we were able to do this over a lifetime, meaning of 25 years for approximately 6.5 million US adults, we could prevent 292,000 cardiovascular disease events and generate 260,000 quality adjusted life years. So these numbers, not really important, but to know here that there are some undeniable benefits that we are both seeing in real time and projecting with the way that food as medicine is expanding across our country. And now I'd like to turn it over to Heather to be able to discuss the ways that food as medicine is supported through policy and funding levers.
Thank you, Meghana. This is a really exciting time for food as medicine. The federal government and the Biden administration in particular have shown immense support for the expansion of food as medicine initiatives. In September of 2022, as many of you may know, the White House convened stakeholders from across the government and the country to develop a national strategy on hunger, nutrition, and health. And that national strategy was developed as part of the historic convening. It hadn't happened since it was like 50 years before that we'd had a convening where we were talking about a national strategy on hunger. But as part of this historic convening, one of the specific levers that was endorsed was expanding access to food as medicine interventions, specifically for Medicare and Medicaid beneficiaries. And as part of the strategy that was developed, the Centers for Medicare and Medicaid Services committed to helping states with this process. In fact, the Centers for Medicare and Medicaid Services have since released a framework for how states can propose to cover health-related social needs services, including nutrition services. And the Centers for Medicare and Medicaid Services have also clarified exactly what health-related social needs benefits can be covered and which payment pathways can be used. Also, as part of this national strategy, both Indian Health Services and the Veterans Administration also made their own commitments, promising to implement pilot produce prescription programs for the specific populations that they serve, and those programs are now up and running. More recently, in January of this year, the first ever Health and Human Services Food as Medicine Summit was held in Washington, D.C., and this all-day event was an opportunity for policymakers, advocates, researchers, and a wide variety of stakeholders with equities in the food as medicine space to come together to discuss why food as medicine is important, what actions are being taken to advance uptake, and what stakeholders can do to bolster this work. With this momentum around food as medicine, there has been increasing interest in the way that these initiatives can be supported financially. And we'll turn to talk about those ways now. I think it's important to start by understanding, as many of you may already understand, that as a general rule, Medicaid does not provide coverage for food as medicine services like medically supportive foods. But there are several flexibilities and payment pathways that can provide funding for these initiatives, including those that you see here on the slide. These payment pathways vary by what population they can cover, what food as medicine methods they can fund, among other factors. One of the most popular and important pathways for funding nutrition or medically supported foods is through an 1115 Medicaid waiver, which we'll explore in more depth in the coming slides. Outside of these waivers and Medicaid, we can also look to other sources of funding in places like the Older Americans Act, U.S. Department of Agriculture grants, or other pilots to help support these programs. In this presentation, we'll provide an overview of 1115 demonstration waivers, grants and pilots, and U.S. Department of Agriculture grants. So starting with Medicaid 1115 waivers. As I just mentioned, Medicaid does not generally, as a baseline, provide coverage to pay for food. Medicaid 1115 waivers allow state Medicaid agencies to apply to the Centers for Medicare and Medicaid Services to ask for an exception to this general rule so that they can make specific changes to their Medicaid program. 1115 Medicaid waivers represent one of the broadest ways that food as medicine goals can be implemented in the healthcare system. For our purposes, we'll talk a little bit about how an 1115 waiver can empower Medicaid to pay for a full spectrum of food as medicine interventions, like the ones that I mentioned, produce prescriptions, medically tailored groceries, medically tailored meals, but also other things like screening for food insecurity and nutrition education. As a general rule, 1115 waivers have to be budget neutral, meaning that the cost to the government has to be the same as it would be with or without the waiver. But recently, this requirement has been loosened by the Center for Medicare and Medicaid Services so that there's more flexibility to cover health-related social needs, services, and also some of the infrastructure that's required in order to provide these services. At present, that limitation is that spending on health-related social needs services is limited to 3% of a state's Medicaid spend, which is actually a pretty significant amount of money. 1115 waivers also have the broadest reach of all Medicaid payment pathways in terms of the potential populations that can be targeted. As I mentioned earlier, there's been a lot of excitement and momentum to expand access to food as medicine across the country. The map that's on the screen details the extent of that movement across the country in terms of which states are using waivers to expand coverage for food and nutrition, plus other types of supports like housing supports. Currently, there are 14 states across the country that have either approved or pending 1115 waiver proposals that include coverage for the direct provision of food. The states with approved waivers include states like California, Massachusetts, North Carolina, New Jersey, New York, Oregon, and Washington. And I'm now going to turn it back to Meghana to talk about some of the funding mechanisms other than the 1115 waivers that can be used to fund food as medicine programs, such as grants and pilots.
Thank you so much, Heather. So as Heather mentioned, in addition to these 1115 Medicaid pilots, states and other food as medicine organizations have found sources of funding through state budgets, state bills, federal coronavirus relief funds, and external organizations. So on the left half of the screen here, we've offered sort of 3 state examples of the use of various different sources of funding to support food as medicine. So for example, in California, they were able to leverage the California state budget for 2021 to be able to pioneer a medically tailored meal program for 4 years, where they offered patients with diet-related diseases access to these tailored meals for 12 to 24 weeks. And then in North Carolina, they were able to use federal coronavirus relief funds to support a produce prescription pilot by partnering with a nonprofit organization within the state, Reinvestment Partners. And that actually went so well that in 2023, the North Carolina legislature allocated $10 million to Reinvestment Partners. And this is actually believed to be one of the largest investments in produce prescription programs, if not the largest in the United States. And then finally, in Virginia, there was a notable legislative effort that involved passing a bill to establish a 3-year produce prescription program at the state level. So now if we turn over to the right half of the slide, we can see that private and public entities such as the Elevance Health Foundation, the Rockefeller Foundation, and the American Heart Association really complement these state-led efforts with substantial financial support. So you'll see the Elevance Health Foundation announced $30 million to assist with any Food is Medicine initiative, the Rockefeller Foundation, in association with the American Heart Association, pledging $250 million. And so this is money that they're offering for Food is Medicine initiatives to apply for, to be able to really support them to that initial seed capital. And while these funding sources are often time limited and may not offer the same level of financial stability as the other pathways we've discussed, they are critical in establishing the groundwork for more comprehensive and sustainable Food is Medicine programming. And so I'm now going to turn it over to Heather to be able to discuss another funding pathway through the U.S. Department of Agriculture.
Thank you so much, Meghana. And as someone who works in the food policy space, funding from the U.S. Department of Agriculture is near and dear to my heart. And the reason that we talk about it is some of the other funding streams that we've talked about are through like the healthcare system or from state governments or support from philanthropic organizations that specifically target Food is Medicine programs. And while I'll talk about a U.S. Department of Agriculture program that does specifically targeted support at Food is Medicine, there are other funding streams as well that can be used to support Food is Medicine programs that may not be intuitively something that programs think about when they're trying to develop ways to expand the communities that they support. And so we'll talk about those as well. So first I want to talk about a program called the Gus Schumacher Nutrition Incentive Program, which is commonly referred to as the GusNIP program. Through this program, the United States Department of Agriculture provides funding directly for Food is Medicine programs through grants that support produce prescription initiatives. GusNIP initially started as a program to incentivize SNAP participants to purchase and consume more fruits and vegetables. And the way that it did that was by providing matching funds to SNAP participants who were purchasing produce with their SNAP benefits to increase their purchasing power. And so for every dollar that a SNAP participant would spend on fruits and vegetables, it would be matched with another dollar for the purchase of more fruits and veggies, up to a set limit. And for the reasons that we talked about earlier, this program, this nutrition incentive program, is not classified as a Food is Medicine program because it's not limited to SNAP recipients who have certain health risks or conditions, and it's also not prescribed by medical providers. But it does help to improve the diets of participating SNAP recipients, helping to prevent or manage diet-related diseases. And based on some of the evidence that was coming out of that program and the successes, the program was expanded in 2018 to add funding specifically to support produce prescription projects. And this funding supports projects that involve healthcare providers in providing those prescriptions to fruits and vegetables for patients who are at risk of or have diet-related illnesses. And these projects are intended by the U.S. Department of Agriculture to help study and evaluate the impact of fruit and vegetable prescriptions on reducing food insecurity, and then also their impact on healthcare utilization. So that's the program that specifically targets Food is Medicine programs. The next category that I want to talk about is not something that's specifically geared towards Food is Medicine programs, but can be used to support it. And that is the U.S. Department of Agriculture support for regional food systems. For example, they have a program called the Local Food Promotion Program. And last year, that program awarded nearly $750,000 to a farmer's Food is Medicine project in San Diego, California. And the funds that were awarded were intended to help establish contracts between local farms and Food is Medicine providers so that they could source medically supportive foods from small local farms, mostly operated by disadvantaged and BIPOC producers. So this program, right, which is to promote local food, demonstrates how Food is Medicine initiatives can tap into those and effectively use U.S. Department of Agriculture funding that might be aimed at a broader regional food system development to support their local economies, their food systems, but also their Food is Medicine programs. And the last USDA funding category that I want to highlight is the SNAP Education Program, which some or all of you may be familiar with. But this program provides support for the nutrition education component of many food as medicine programs. SNAP Education has a budget of $464 million. And because of that, it is the nation's largest and one of its most important sources of nutrition education and obesity prevention programming. As I mentioned, many food as medicine programs not only provide food, but they also provide education to promote healthy diets. For example, produce prescriptions or medically tailored groceries might be complemented by some programs with nutrition education or cooking classes. Some educational materials that are provided may be targeted to specific populations in order to provide culturally appropriate recipes or as a means of transferring Indigenous knowledge. So as you can see, there's a variety of opportunities to use other sources of funding, like Department of Agriculture funding, to provide really critical support for food as medicine interventions, including many sources of funding that we don't have time to mention here. And with that, we want to transition to highlighting 3 best practices for advancing food as medicine programs within a state, including partnering with community-based organizations, investing in the infrastructure needs in order to support the expansion of food as medicine programs, and identifying multiple funding streams to support these programs. And with that, I'm going to turn it back over to Meghana to go more in depth into each of those practices.
Wonderful. Thank you so much, Heather. So to begin, the first best practice that we'd like to cover is that partnership with community-based organizations. So at their best, these partnerships are reciprocal. Community-based organizations are able to help states advance their food as medicine initiatives because they have their feet on the ground. They are able to identify the gaps in access and service, collecting useful data, and advising states on developing strategies for really improving local-based food as medicine programming. And then states, in turn, can assist these community-based organizations by providing guidance on accreditation, navigating healthcare systems, and clearing any obstacles that CBOs may face in delivering care. And an example that we'd like to highlight is from our state of Massachusetts, an example of where states can help CBOs. And the CBO that we're highlighting here is Community Servings. And Community Servings has partnered with researchers to co-author 2 peer-reviewed articles on the benefits of food as medicine. So this provides the state with data on food as medicine initiatives, as well as advising them on strategies for expanding their food as medicine program. And the state has also helped Community Servings in that it's given forums for Community Servings to periodically publicly speak on issues related to food as medicine in front of the state legislature, where Community Servings really does offer recommendations to ease the delivery of services within Massachusetts. And with that, I'll move to our second best practice. So the second one that we've identified and want to share with you is investing in that targeted infrastructure. So if you remember from a few slides before, Heather talked about the local food promotion program, where those funds were used to establish contracts between local farms and food as medicine providers. So this is kind of what we mean about targeted infrastructure funds. We know that food as medicine, whether it's a produce prescription program, a medically tailored meal, or a grocery, it requires substantial infrastructure, whether that means the transportation of the food, the packaging of the food, the actual people who are working on the food as medicine programming. And so this means we need to invest in the technology, the supply chains, the workforce training, and the community education and outreach to really build robust programming. And the example that we've offered here is from the state of Arkansas, where in their 1115 waiver program, so again, this is their Medicaid 1115 waiver, which is titled Our Home. And they've sort of established these intensive care coordination units for healthcare services and community supports for at-risk population. So by building in their intensive care coordination, whether that be the actual dialogue between the healthcare provider and the food as medicine organizations, this assists in that efficiency and effective providing of care for patients. And with that, we'll move to our final best practice, which is an identification of multiple funding streams. And what we mean by this is identifying any combination of funding sources like an 1115 Medicaid waiver, a GusNIP grant, or other private organization support. Multiple funding sources not only offer states or organizations more flexibility in the services that they're able to offer, but you also get the benefit of more technical assistance from supporting organizations and connections to other food as medicine providers and actors that may offer experience and opportunities for expansion. And for this category or best practice, we'd like to highlight the state of North Carolina that has been able to support their statewide produce prescription program through the braiding of funding from GusNIP and 1115 waiver and previous statewide coronavirus relief funds. So we conclude our 3 best practices and really want to round out our presentation by bringing back the initial quote that Heather read for you all. And that is that food as medicine refers to the spectrum of services and health interventions that we've covered today that recognize and respond to that critical link that we also talked about between nutrition and chronic illness. So as a summary for our presentation, we want to note that this was a high-level overview, but we hope that we sparked at least some interest, maybe a little more interest, and some areas for further discussion. And with that, we would love to open it up to questions, acknowledging that many of you in the room might be experts and may know way more than we know. And so we would really like to welcome your expertise to address any questions relevant to your work or your experiences. Thank you all for your time.
Thank you, Heather, and thank you, Meghana, for such an very insightful presentation. The information that you provided, I hope will serve as the basics for some of the partners at the state level and at the community level to perhaps start considering establishment of a food as medicine initiative that can benefit the communities that they serve. So it's time for questions. So let me just get a couple here. Please feel free to use the question and answer, the Q&A feature in the program, or even in the chat if it's easier for you. Please send the questions in those through those 2 features. But in the meantime, let me ask you something. I guess this is for both of you. And I know you talked about the partnerships, how you can implement the partnership, the program with these specific partnerships, but what would you think for somebody who is brand new, like a state program who is just beginning to maybe even consider this topic? What do you think are the key considerations when establishing a food as medicine program as a PSC strategy, as a policy systems and environmental change strategy?
I'll jump in, and then I would love if Meghana would add to anything that I say. But I think like one of the most important starting places, Marcella, is to bring together community coalitions. And so that our clinic is at the Harvard Law School, and it's housed under the Center for Health Law and Policy Innovation. And we have both a health policy clinic and a food policy clinic. But both of our clinics provide support to states and coalitions that are interested in moving forward food as medicine initiatives in their communities. And what that often looks like is that as a starting point is bringing together all of these different voices that might have interests in these programs together to be able to talk about their interests, to begin using the same language, and to start mapping out like what the most important priorities are for the communities that they serve. And so I think that coalition building is really one of the most important starting places, because otherwise what can happen is you might have these conversations that are really siloed, where you have a community of people who are really deep and embedded in the healthcare space, who are really focused on health outcomes and improving them, but they're not talking to the food systems and agriculture folks who might be feeding into and supplying and supporting the foods that would be used in food as medicine programs. And so really bringing both of those communities together in order to develop a strategy that's going to work best for them, I think is the most important place to start. And Meghana, do you have anything else that you would like to add on to that?
Yeah, thank you so much for a great question, Marcella. I think that state-specific interventions are really important. So the topics of food insecurity or diet-related disease are not brand new things that Heather and I kind of came up with today, right? These are existing conditions that manifest differently in every state. And chances are there are organizations, there are community partners that are already working on ways to solve this. And as Heather described, it's really about bringing them together and figuring out what are the critical needs for our local area and what are the strengths of the organizations that might already be doing stuff and could possibly expand upon what they're doing.
Great. And then as a follow-up to that question, who will be some of the, again, for somebody who's just beginning to establish a program to improve access to healthy food and food as medicine program, who will be some of the perhaps non-traditional partners that many people might not consider? From your experience, have you learned of programs at the state level that have partnered with some groups that, you know, that are not kind of on the radar when you first think about establishing programs like this?
That's also like a really great question. I'm like thinking about some of the coalitions that I've had the honor and privilege to be able to be involved with and the types of partners that they're bringing together. And so I'm thinking about one in particular, and that the coalition was led by an organization that runs a food bank in the state. And as part of that work, they brought in state agency officials, so people from like the Department of Health and medical providers, some not only physicians, but also registered like dietitian, nutritionists, or part of the conversation because they're a really important care provider in this system. Bringing together researchers from local universities who might be able to partner with programs to help study the impacts of these services on participants. Bringing in the participants into the conversation who might be receiving these services and have really valuable insight into how systems are working or not working and things that might need to be considered as part of the expansion. And then, as we mentioned, bringing in the different players across the state who might already be doing these work. So the, medically tailored meals delivery systems that are already in place, or the produce prescription programs that are already up and running. But sometimes too, it's like bringing in programs that aren't doing food as medicine, but might be in this space that's tangential to it. So another really important partner can be bringing in whatever agencies administering federal nutrition programs, so that not only are you talking about food as medicine, but you're also talking with the agencies that are administering SNAP benefits or the women, infants, and children's programs, so that as part of the system, you're also developing an ecosystem where when folks are not connected with the benefits that they are eligible for, that's happening as part of that process, that they're getting connected with programs to address food insecurity, and that food as medicine programs are not kind of taking the place of a federal nutrition program. They're filling in the gaps where those programs are not working or a person is not able to access them for some reason. So those are some of the stakeholders that stick out in my mind. Of course, also involving, the members of the agricultural community is really important. The entities that are going to be growing, producing, putting together meals or helping to deliver those meals is also a really important part of the conversation.
And actually, you answered my other question, because one of the concerns for the partners, for example, that our community members serve are people who perhaps are not eligible to participate in some of the government-funded program, even though some states are more flexible in those requirements. So how can people know about these programs that can help them with their needs, their food insecurity needs, or food as medicine needs? I know some states are better at promoting their programs, but I know in other areas, those programs exist, but people don't know how to access those.
I was pausing to see if Megan wanted to jump in.
You take it away, Heather. Yeah.
So different jurisdictions are trying different things, Marcella. You're right that it's like really complicated, that there are some jurisdictions where, unfortunately, like large segments of the population are not covered by Medicaid or by other federal nutrition programs, which is really unfortunate. There are food as medicine programs that are able to fill that gap, but oftentimes they're doing it not through like an 1115 waiver, for example, but they're doing it with the support of philanthropic funds that allow them the flexibility to be able to serve a broader population than they might otherwise be able to. But one of the other things you raised is like, how do you communicate and get the word out about these programs? And a couple things that I want to highlight is in North Carolina, one of the things that they did with Reinvestment Partners was to create like an outreach campaign where there's information that's being shared between state agencies about eligibility, and they're using that information to be able to do targeted outreach to people who qualify for certain programs, encouraging them to sign up, and then offering them the support to be able to sign up for those programs as well. So improving that communication system is really important. And then the other piece of it is really bringing in the medical community into the conversation to be able to also like fill that communications role. And we know and are very sensitive to the fact that medical providers are being asked to do so much already, that you can't really expect like a primary care physician to be well positioned to be able to identify like, oh, here are all of the programs and here's how I can connect you. But making sure that they're part of the conversation and are positioned to be able to screen for food insecurity and then to be able to make a referral to someone who can actually answer those questions and connect patients with those services that are available in the community is also part of that communication ecosystem that like in some places we're still really working to develop.
Right. I have a couple of other great questions from the participants. Such a great initiative. Thank you both for sharing this information with us. Sorry if I missed this in the presentation, but could you please elaborate on the geographical scope of implementation size of these interventions, like coverage or the interventions among rural communities?
Yeah, I mean, I think Heather's pausing for me to do this. So my my clinic experience at the law school has actually entirely been about sort of understanding the scope of implementation and how that changes in different state environments. For example, getting produce prescription program in Alaska would be completely different than getting a produce prescription in New York City, right? These geographically look very different. The populations are very different. And this is where we really want to go back to our best practice number one, right? And the geographical scope or implementation sites can literally be anywhere, right? It is about the importance of finding those communities and community-based organizations that maybe have begun working in these areas and doing things, or even starting something new. I think the point is that there are many funding streams to pull from. It's really about the creativity that you can put into building out a food as medicine program. So for the coverage of the intervention among rural communities, we think about a state like Alaska where transportation is a real difficulty, right? And so here your community partners are going to be those people who are driving out or boating out or, getting to the places where populations may need the prescription programs or medically tailored groceries. So I guess to answer this question, if I had to, and Heather, please add on, right? It's about the creativity of what you can create in your programming and where you scope your funding from. And have you really talked to the population for what they need and catered your programming around that?
Yeah, and what we've seen is that some states, rather than rolling out a program statewide, they start by targeting a specific area or region to test it and see how it works and to kind of develop those lessons learned that they can build on before they expand. And in particular, I'm thinking of North Carolina, who started with 3 regions of the state, but didn't start it as a statewide program. And so that can be one option as well, as you're developing learnings, to be able to start in an area where there are already service providers in place and you might have more infrastructure, and then to figure out like what's going to work as you try to like broaden the reach to other communities.
Great. It's definitely key, the partners that you are working with, and also working with them to assess the needs first before you just go and implement the program. I have another question here. Have any of these efforts integrate promotores de salud or community health workers to be part of the design, especially reaching out to Latino population, for example?
That's a really good question. And actually, the Rockefeller Foundation, which is one of the philanthropic organizations that we talked about in our presentation, in sort of preparing this, we had found that they actually are supporting an organization called Adelante Mujeres, which is in Washington County, Oregon. And so Adelante Mujeres was a produce prescription program that has actually been in effect since 2014. And it's actually through Promotoras de Salud in Oregon. And so they had started this to combat obesity and diabetes and other chronic diseases. And then they found out about the Rockefeller Foundation grant and the some millions and millions of dollars that they're offering to organizations. And then they applied and became actually an award recipient for $200,000 to be able to expand their program. Yeah. So it's called Adelante Mujeres if you're interested in looking. But their model is really beautiful because it especially targets families and is for families within the Latino community in Washington County, Oregon.
Oh, wow. This is a great resource.
Yeah.
And then I have one last question here. Are there any toolkits or any type of resources that you guys would recommend, for people that are trying to start programs like this or working on any type of PSC change to kind of get their work started?
That's a fantastic question. Not only does the clinic and the center where I work and where Megan has been, studying for the past year, do offer technical assistance to states and communities and coalitions, but also part of our work is developing those sorts of toolkits and resources that can be used by communities and organizations that we're not able to partner with in our work. And so, Marcela, I think what might be helpful is like I follow up with you and you're sending out your slides, I can share with you the links to some of those materials. Because we do have publications about food as medicine broadly. We have publications very specific about how do you expand produce prescription programs. And so would love to be able to share those so that anyone who's listening who might find them helpful has access to those resources.
Great. Yeah, that will be great. Since, like I said, we're going to be following up with the participants, we will be able to send those resources. And I would like to mention also that Nuestras Voces Adelante will be releasing a brief that we develop as part of our work on equity, and is an equitable food systems and cancer survivorship in Hispanic communities. That's coming up soon. So I just want to announce that we developed that brief in collaboration with our partners from Change Lab Solutions. So I want to thank you both as we draw close to the end of our webinar. That was a great presentations. Those were great presentations, and we really appreciate the fact that you took the time to be with us today. And of course, I want to thank all the participants as well. Next slide, please. This is the webinar evaluation QR code. So please, if you can do it right now, it's brief, I promise. It's not a long evaluation survey, but we really use this information to, like I mentioned before, to help us improve our programs. And also we get ideas from people when they suggest maybe potential topics for webinars. So please help us improve our program, and then also to any type of comments, any type of input that you have from us, we would really appreciate that. And I also would like to announce that our next webinar for the series on upstream approaches in cancer prevention is taking place on May 7 from 12 to 1. And it's going to be Introduction to Built Environment Approaches for Addressing Health. We're going to put the link on the chat so everybody will have access to it. And again, I want to thank everybody for participating. And please, when we send the follow-up email with the information, with the slides, and also with some of the tools that Heather mentioned as well, we will also send the link to the evaluation. So again, Heather and Meghana, thank you very much for participating with us, and we hope to continue talking to you in this important topic, and maybe we'll have you again for another program that we do as part of the TriNetworks program as well. Thank you very much, and thank you
so
everyone.
much.
Thank you.
Thank you,
everyone for joining us.